Actually Callum down, but he might be busy on the ward, I guess.
Is Aisha meant to?
Hi.
Hi, Aisha.
Hi. I'm just sending Callum the performers and everything because he doesn't have access to anything.
Right.
Oh, right.
Okay.
Oh, thanks, Ashley.
Yeah. Sure. Okay. Yeah.
Uh,
Aisha, are you happy to start with recording and then? Yeah.
Yeah, that's fine.
Is that
We will
okay?
start.
Yeah.
That's okay.
Yeah, sure. Thank you. Yeah. Okay. Shall we kick off? So the first patient is Margaret Baker. Looks like a need nose patient. Does anybody know the patient? Okay, if not, I'm just going to read about the performer. So it's 86-year-old, diagnosed with stage 3A follicular lymphoma with a FLIPI score at 4 in 2023. And this is diagnosed in Gloucestershire and was on active surveillance and moved to a nursing home in Bloxham and now has reported new night sweats in February and had a DVT in April, walks with relators and independent self-care. I think it's to review the recent CT scan.
Thanks. So I don't have any prior imaging. I've just got the scan from March 2024, and it shows lymphadenopathy within the right side of the pelvis. So right external iliac nodes here, measuring up to 37 by 23 millimeters, and then multiple right inguinal nodes as well, measuring up to 37 by 26 millimeters, and the femoral vein basically loses opacification. So they had a DVT scan which was positive. Above the diaphragm, there are no nodes, but there is just a right apical area of opacification, which just needs some sort of correlation with prior imaging, or because it might be radiotherapy change if they've got a history of radiotherapy, but if not, it should be followed up if it's new.
Sure. Thanks, Nia. Yeah, so I can see that Neve is proposing rituximab with steroid, and I think she's already discussed that in the view of 86-year-old with follicular. I think that's very reasonable. Yeah. Okay. Shall we move to the next case? And the second case is Roger Gilbert.
I know this guy.
So Ashley's seen him. Yeah.
Yeah, perfect, Ashley.
He got 78-year-old gentleman diagnosed with SLL of the marrow just over a year ago, who has represented with a large abdominal mass, essentially. So I think he's just a PET, and there's a biopsy ordered. His LDH is actually normal. He looked a bit kind of high grade and sick, but maybe I don't think the PET is in keeping with that really. But anyway, we can look at it.
Yeah.
Thanks. Yeah. So the PETs. Sorry.
Oh, sorry.
Oh, so there's a PET from the 13th of April, and essentially he's got above the diaphragm small volume lymph nodes at pretty much every station and a small right pleural effusion, but below the diaphragm he's got larger volume lymphadenopathy, but this is all just faintly avid on the CT, so it's not particularly worrying for high-grade disease, although it's quite, the largest node is 39 by 37 millimeters. The spleen measures 17.8 centimeters craniocaudally.
Grand. Thanks. I have organised a biopsy. Is it still okay to go ahead with that? Yeah.
So, Louise, sorry to interrupt. Can I just ask what's the max SUV? On the...
I don't think it was reported. They just said faintly. They just said diffuse faint uptake. And this is kind of representative, so it's not, you know.
I just
no
interrupted
necrosis and
max SUV is less than 5.
Yeah.
So there's 3.
So I personally think in this situation I wouldn't biopsy. It's one of the sort of The negative predictive value of the PET here is really useful for high grade. So yeah, I think probably we could treat as CLL, SLL.
Radio. Okay, yeah, it's good.
Shall I cancel the biopsy?
Yeah, I think so.
Thanks.
We can discuss with the patient about what's the CLL treatment. So would you want to discuss the treatment at this point, Ashlyn?
Yeah, that's fine. I can give
Yeah.
a ring. Yeah, I know. Yeah, brilliant.
Should we move to the next case?
Well, should we discuss what treatment?
Oh, sorry, apologies. Sorry, I've sent off TP53, but it's not back yet.
Okay.
But he is a bit sick, so I guess maybe something like Veno might be more helpful. He's 78, so I don't think Veno would be the best option.
And not a BTK inhibitor just because you're worried about speed of response. Is that what you're?
Yeah, his hemoglobin's like, well, yeah. I guess that was it. He just didn't look great, but as there's nothing in the bloods that really backs that up. But we could think about a BTKI, especially if he's CP53 disrupted.
So should we just leave it should we leave it a bit open and then we can sort of rediscuss if he's coming back to clinic? How about that? So just say BTK or Ven-O to discuss with patient and await TP53.
Yeah.
Good.
Sounds perfect. Yeah,
Sorry,
okay.
can I double check that this is for the previous patient, so for Robert.
Roger
Gilbert. Okay.
Yeah. Roger Gilbert.
Thank you.
The next patient, Christopher Jackson. I don't have a performer. So
Can you-
is anybody?
Yeah, hi Dame. It's Chris here. So we've seen this
Hi.
chap. He's currently inpatient in the JR.
Mhm.
He's a 75-year-old chap with little in the way of comorbidities, who initially presented to ENT with symptoms of sort of nasal blockage. Was referred there where they did a biopsy after having an MRI which showed sort of this large nasal mass affecting both sides, but more so on the left, which has come back with sort of unusual histology in the sense that it's got some T cell markers there with positive CD2, CD3 and sort of weak CD4. I think its location they were querying as to whether or not this is a natural killer T cell lymphoma. He's had a CT neck, chest, abdo-pelvis, which hasn't shown much in terms of lymphadenopathy or organomegaly, but it has picked up some pulmonary nodules as well. He's currently under the medics. He's had an episode of upper GI bleed, and he's had an OGD which has shown a lesion in the distal third of his esophagus, and also one within the fundus of his stomach that they've clipped and given adrenaline to. So we haven't started steroids or anything yet because of that, and I think we were going to try and get him across to the Churchill ward. He's also had a PET CT of which the formal report isn't back yet.
Yeah. Thanks very much, Chris.
Okay.
Dan, I think we've got the email about this patient over the weekend, and this is the extranodal NKT patient I was going to see in the clinic, but it sounds like he was admitted on Monday.
Yeah, that's right. So
Dan,
we had a nasal biopsy.
yeah.
Nasal biopsy
Yeah.
from the third, which did show an EBV positive atypical T cell population with high proliferation, and that it's pleomorphic, so entirely in keeping with a NKT cell lymphoma of nasal type. And I can see also that there's a GI biopsy in our system as well. So that one's ready.
Right. Thanks very much. Louise, can we have a look of the imaging?
Yeah,
Now we have a
absolutely.
PET. Yeah.
Yeah. So the PET was done on the 11th of April, and as mentioned, there's a large paranasal kind of mass extending into the pharynx, which is based on the left side, and it's intensity avid with net EV max of 24.6, and then throughout the lungs there are multiple pulmonary nodules bilaterally. There's a splenic lesion. left adrenal and left renal lesion, a gastric fundus lesion, as mentioned, multiple bone lesions and peritoneal lesions. Really extensive disease.
Is there a bone marrow involvement? I think its count is very low as well.
25.
So there are focal lesions within the sacrum,
In the bone, yeah, sure.
but the rest of it's not diffusely involved.
Yeah, it's stage 4, right?
Yes.
Yeah, perfect. Okay, so Chris, have you arranged EBV PCR being sent?
Yes, we sent that.
I think, yeah, that would be great. So, because I think that would be a good marker to sort of monitor for early response. And how is his performance status, you think?
Yeah, it's borderline. He's about PS1 at the minute. I mean, it's difficult because he's quite pre-syncable, having had the bleed. But I think that should hopefully stabilise. But aside from that, I mean, he's got hypertension and BPH, and he's on medication for that, and nil else really.
Sure. Yeah. So obviously, I think that currently it is a bit tricky to treat with steroid in view of current GI bleeding. And I think the standard treatment from our perspective is DDGP and basically GDP with our asparaginase treatment. So I think it looks like it's got quite aggressive disease. I'm not sure that in the front with this nasal lesion, do we just go straight for radiotherapy, or straight to chemotherapy, or do we think we need to do a bit of radiotherapy to help with the symptoms? I think from upper sort of nasal symptoms, he mainly have epistasis, right? But anything else? Yeah.
We would normally then make those straight with chemo in a stage 4.
Okay.
I mean, the other thing just to flag up is as you get older, I'm no big expert on using asparaginase at all, but so I would, whoever does sort of treat him when he's on the ward, I would have a chat with Andy Pennicott or Rob or somebody, because it's really toxic, asparaginase, as you get older. I think you should still have it, but it's whether you dose reduce or whatever. I would get their advice because they're just so much more used to asparaginase than we are.
Yeah, exactly. I think
depending on his response, we could think about sandwiching in some radiotherapy, because we know it is important for local control in this disease. But it might be useful, if possible, to get an MRI scan of his head done at this stage before or early on in treatment, just to help map out the extent of his disease for radiotherapy if and when he needs it.
Dan, do you know if
that's requested? Yeah.
Do you know if the GI lesions were biopsied? Just because they're probably disease, aren't they? And the risk is actually high.
They were biopsied.
They were biopsied. Yeah.
It's pending, Toby. Yeah, it's pending.
The risk is actually holding off treatment because you're worried about them. I would probably just crack on, actually.
Yeah.
They're only going to they're probably malignant, and but I don't think that's not a reason to give the steroids that he needs. Personally,
I agree. Certainly if it's malignant, I'd definitely
get him across quite quickly and get going.
Yeah, we'll start DGP. Yeah. Okay. Thanks very much. Okay. So the next patient is Charles Howard. So this looks like a referral from respiratory team, and it's a 30-year-old man referred by surgeons after incidental finding of lymphadenopathy on CT scan, but also with splenomegaly. And at the time, the core biopsy from the cervical lymph nodes showed non-necrotizing granulomas, and this is in last November. And usually fit and well, and I think the recent scan showed increasing avidity of lymph nodes. And should we have, so they're asking whether this is concurrent lymphoma. Should we have a look?
Thanks. So I've got the PET from the 28th of February at the top, and then November 2023 at the bottom, and it shows bilateral, lower cervical, mediastinal and high-lower lymph nodes. There's also a couple of avid but small nodes within the right axilla, and then some focal avid lesions within the spleen and upper abdomen. And I think that it was externally reported, and the comment was that there's been an increase in avidity, and they seemed more kind of prominent, but I think the distribution still in keeping with sarcoid. The original biopsy was in the neck. Yeah, I think it's all still compatible. You can't say for sure on imaging that there isn't something concurrent. And if you wanted to biopsy, for example, the right axillary node, which was increased in size and avidity, we could do that because it's a low risk thing to do. But I think the behaviour is perfectly in keeping with sarcoid.
Right. Okay. Should we just tell them that to arrange a right axillary biopsy, and then
so where is that? Sorry, because Ling Pei did email me about this case. So it's right axilla. It's quite small, isn't it?
Yeah.
Should we ask them to take it out, do you think?
Excision, yeah.
It's just they've done a call already, haven't they? But I don't know, it's difficult. I'll just email Ling Pei saying, look, as far as we're concerned, it still looks like sarcoid, but there is a small right axillary biopsy, node to biopsy if you want to. But.
Sure. Thanks. Shall we move to the next one? And so the next one is Haley Reader Curtis. Graham, is your patient?
Yes, I think I've seen her once, I think, as a 2-week wait. If I remember rightly, she's got neck lumps, quite juicy though. So I think it's a pucker one. So she had a biopsy and a PET scan.
Yeah, she's 37. It looks like from your performer, she's 37 with right neck lumps. Dan, I think you've got the biopsy now, right?
Oh God, sorry, microphone off. Yeah, cool there. So it's Haley Reader Curtis. We had a biopsy from the 9th of April from a right cervical lymph node, a core biopsy, which shows classical Hodgkin lymphoma.
And the PET scan, I think, shows a bit more disease than I thought it would.
Yeah, so the PET's from the 9th of April, and she has right supraclavicular lymphadenopathy, but also a right apical pulmonary nodule disease within the mediastinum as well. Nothing below the diaphragm. But yeah, there is that pulmonary nodule, which is 34 millimeters.
It's a proper lump in the lung, isn't it? That one. Yeah. Okay. So I mean, she's actually quite low IPSS. Very low. Well, basically normal hemoglobin, low inflammatory markers, etc. So I'll probably talk to her about both and get her thoughts. So ABVD versus escalated BCOP-DAC. Discuss with patient, I think, if people are happy with that.
Yes.
Yeah, sounds good.
Yeah, perfect. And next one is Kirsty Ski.
Yeah, she's somebody else I know. She's again a fairly young, 35 or something like that, year old lady, teaches English, doesn't know who her favourite author is though. I always ask English teachers that, they never know. And she had a neck lump as well, biopsied. Hodgkin, I mean, we do know this is already Hodgkin. And so she's had a PET scan as well. But Dan, we should probably come to you as confirmation though first.
Yes, Graham, thank you. I saw this on the list. So this was a core biopsy from a left cervical lymph node the 4th of April, and reported by fellows being classical Hodgkin lymphoma. And I agree with much of his description. I'm just a little bit cautious because we haven't got absolutely knockout HRS files. I see this as from a cervical lymph node. You're obviously very suspicious of Hodgkin's. This is a real borderline one. If possible, I would like to have a nodal excision for confirmation.
Oh, Dan, that wasn't on the report.
It's surprised as Hodgkin lymphoma. It's only on review. I'm a little bit nervous that we haven't got absolutely barn or HRS. I think it probably is, I personally prefer to have more tissue if possible, Graham.
Okay, all right, thank you. Totally understand, Dan, if that's your view, but yeah, should we look at the imaging?
Yeah, and the PET-CT from the 11th April shows this left supraclavicular fossa node that was biopsied 30 by 21 millimeters, intensely avid with an SUV max of 16.3, and then disease also within the anterior mediastinum, but nothing below the diaphragm. Bones and spleen are fine.
Okay, Dan, can I just briefly come back to you? What are the cores like? Because they were done at the Manor. They weren't done by our usual expert core biopsia.
They were not great, Graham. That's part of the problem. They're a little bit scrappy. They are fibrotic. There are nodules. The microenvironment is right. Everything is there, apart from the fact that we haven't got these kind of really characteristic HRL cells. There's probably across three of us, there probably be a slight range of confidence. What I could do, Graham, if it's helpful, is just double report this past Gareth. But my view personally is I wouldn't want this to be the sole diagnostic sample for this patient. I'm sorry.
Yeah, because I wonder, I mean, Shahil, do you think it would, our issue is she's actually due treatment a week Friday. She's very anxious. It'd be quite difficult to stop and arrange for a node to come out because that'll take quite a while to organise. But if we had a Shahilogram biopsy, multiple wide bores, Shahil, what do you think? Would that be doable?
Yeah, we can probably do it on Friday morning.
Yeah, okay. I'll give the patient a ring because I want everybody to be confident. Obviously, this is Hodgkin's. So I'll give the patient a ring and maybe we'll try that. Anyway, assuming it is, she's actually quite keen to go into the radar study. I've had a chat with David already. Maybe he wants to comment, but obviously radiotherapy, it's early stage disease. She could have it. The fields do go down below the coronary ostia, so it's not without risk. But I have to say the patient herself is relatively, is keen on, if possible, a chemo-only approach. So she's very comfortable with sort of 3 and stop or 4+ radiotherapy if she's interim PET positive, which is essentially what radar is.
Yeah, but as she's more than 5 centimeters MTD, we should record her as a one to discuss radiotherapy or recommend discussion of radiotherapy. The wording in the trial isn't ideal because it sort of suggests recommending radiotherapy, but we never do that. We always discuss it with the patient in these situations. But yeah.
Shall I ask her to come and see you, David?
Yeah, I think it's worth. Yeah, I mean, certainly if we're saying she's in that category in the trial, we should have the discussion.
and do we need? Yeah, what I can't remember is if we need to decide before she's randomised.
We do because it's stratified by that decision.
Time is very tight, then, David. But
no, I don't think that it's reasonable to make the decision radiotherapy or not upfront. The decision should be discuss radiotherapy or not.
Yeah.
It's like you're not having radiotherapy or you're going to discuss radiotherapy. And that's what I mean by the wording in the trial being wrong. It's not practical or realistic to make an upfront decision like that.
Okay. For purposes, I don't want to dominate, but for purposes of randomization, what should we say though, David?
Yeah, that we're recommending radiotherapy.
Oh, recommending it. Fine.
Brackets discussion.
Yeah.
Because that's our, that's what's realistic.
Yeah.
They decline it.
Yeah. No, that sounds good. Sounds good.
To say, Graham, if we have the biopsy on Monday, we will rapid prep it to the lab and we'll have a report out by Tuesday afternoon.
That'd be really helpful. Thanks, Dan.
I'll prioritise that. And if you could come to me, I'll make sure it's done.
Thank you.
Thanks, everybody. Let's move to the next case. And I think the next one is Claire Greenaway. So I think this is the patient. Yeah.
So I saw her yesterday.
You saw her yesterday, so yeah, if you want to take it.
The end of the clinic. Yeah. So she's 43. She's a chef. She doesn't know what her favourite food is. No, I didn't ask her. She basically presented with some word finding difficulty texting, and some right arm numbness. So it's all fairly subtle. And then she was basically spoke to an out of hours GP, sent her to the JR to exclude a stroke, had a CT, and then had a big a big CNS lesion. So she's gone on and had a biopsy and an MRI that we can look at, and a CT, which I think we looked at before. Probably some simple liver cysts. So it's really just to confirm this is a primary CNS lymphoma. I've spoken to her about the Optimate study yesterday and given her a PIS. So but she's definitely matrix fit. She's pretty overweight. She's about 150 kilos, but she's 43 with only asthma as a comorbidity. So I think she's good for matrix. So I guess, Dan, I don't know if you guys in Hempath have actually seen it yet.
Yes.
But
we've seen. I've seen the Neuropath slides, Toby, that was sent over this morning. So we had a biopsy from Claire Greenaway on the 16th. This is a very high grade looking B-cell lymphoma, vaguely Burkitt-like phenotype. Morphologically, that's why I've done the full phenotyping. This is very high grade. So the immuno should be back tomorrow or Friday.
Okay. Can you email me if you think this is Burkitt's? I mean, she has no systemic disease, and the initial report on the system is DLBCL. So yeah, please let me know if that changes. Sort of.
Yes, it's large B-cell lymphoma. It probably is just going to be CNS large B-cell lymphoma, but it's slightly monomorphic. You know how these things are. Let's just do the immuno and confirm.
Okay.
Sure. Thanks, everybody. So I think our last case in Oxford is Peter Ward.
Yeah, I can tell you about Peter Ward, Dan May.
Oh, hi.
Hi.
Jack.
Yeah, so he's in his mid-70s and presented with sort of some DAT negative hemolysis, essentially. He has an IgM paraprotein, so he's had a marrow and a CT scan, and his hemoglobin started to drop again. He's had no actual treatment, but I have stuck him on some steroids initially for what it's worth. So it's just to review everything and come up with a plan.
Thanks. If he had a marrow at the beginning, right?
He's had a marrow and a CT.
Yeah. Sure. And then it's just to confirm that is LPL.
Yes, that's right. So we had a marrow for Peter Ward at the beginning of February, sort of 30. We'd be keeping with LPL.
Yeah. Okay. Louise.
Thanks. And yes, CT from November 2023 with no lymphadenopathy, but what looks like probably a cirrhotic liver and bilateral calcified pleural plaques and an enlarged heart.
Sure. Thanks.
So I was actually just going to give him rituximab, I think. Or, I mean, we could give him DRC. I don't have any strong views. I think the marrow infiltration was 30%. I couldn't quite hear what Dan said, but it's not
30%.
Yeah, she's not massively heavily infiltrated. So, what does the MDT think? Should we start with Ritux and see what happens?
Yeah.
Seems very reasonable, doesn't it?
Yeah. Is there any evidence of CHAD? There's no CHAD, right?
No.
Okay.
But yeah, that would be a common cause in this condition.
Yeah. Sure. Yeah. Because the paraprotein is quite low as well.
Yeah.
You can see from EPR. Yeah.
No,
Perfect. I think we'll just carry on steroid and plan for rituximab.
Yeah, I doubt that steroids will do much, but the Ritux is due. He's due to start next week.
Yeah. Okay. Perfect. All right.
Lovely.
I think that's thanks. That's all the cases for Oxford.
Okay, great. Thanks, Stanley. Have we got Bucks here? Looks like I just dialed in.
Just before Bucks,
sorry, Graham.
Sorry, can I, we don't need to discuss it now because I know it's Bucks, but can I just ask Louise if we have time after one of the local hospitals for us just to briefly look at Lubo Zaya's MRI head again? Sorry, that's ZAJA and it's LLUBO is Lubo. We've seen it before, but we've got to make some decisions about bridging, and we tried to put them on the MDT but didn't manage to get them. Sorry.
Yeah, of course, that's fine. And I think there was also an add-on Alan McCullough.
There was.
Patient. Yeah, so we can do both of those after whichever.
Yeah. Okay, great. All right. Hi, Bucks. Hello. So let's get cracking. First one is I've got on here is Bryony Adams.
Oh.
Thanks, Toby. So this is a lady with known LPL, mid-88 negative, so diagnosed sometime last year, not on treatment. So it presented then to hospital with melena in December. Had an endoscopy which showed us the benign looking ulcer in D1, which was biopsied. And I just wanted to review that and a PET scan. There were concerns about the possibility of infiltration in that biopsy.
Okay, all right. Dan, have you got the biopsy?
We first of all had a marrow from March last year, reported as being at 10% infiltrate of LPL, and yes, the mid-88 was negative. So then recently a D1 skin biopsy from early January, initially reported as favouring a reactive infiltrate, but we did have evidence of clone B PCR, and there is a fairly prominent B cell infiltrate. So on balance, as interpreted as representing lymphoma of the GD. But given the fact that there's negative in mid-88 and now digging involvement, one would have there is a possibility of this being an MZL, of course.
Yeah. Okay. Okay, and she bled from this lesion. Let's have a look at the PET.
Thanks. Yes, the PET's from April 2020. It's from the 11th of April, and there's this thickening on the CT component in the kind of pyloric /D1 region, and that was actually in retrospect present in April 2023, so a year ago, and doesn't look to have changed over that year. It's avid with an SUV max of 8.2, and then there's a kind of faintly avid opacity in the right upper lobe, which is indeterminate and just should be followed up.
But so just
nodule there.
Sort of isolated duodenal disease. Is that what you say? Yeah. Okay. David, what do you think about radiotherapy here? I don't know, how easy is it to isolate and target the duodenum? This is a sort of marginal zone affecting the bowel, but with a small amount of marrow infiltration with normal counts. Otherwise, could you deliver a sort of palliative dose here?
Yeah, I mean, even I can draw around the duodenum on a CT scan.
Lots of nice fat there for you to.
I just wonder whether that might be a nice option. She's not got much disease elsewhere, but you need to get some local control because otherwise she'll probably bleed again.
Yeah, I mean, Fulgray should control that quite nicely.
Okay.
Without any toxicity, really.
Right. Okay. Good. Next one is Alan Cato.
Thanks. Have you got his biopsy results? Wondering, skin biopsy.
Yes, I did see a skin biopsy.
Oh,
yes.
great. Okay, so Alan Cato is a man in his 70s with had angioimmunoblastic T-cell lymphoma about a year ago, treated with some sort of dose-modified shock to 6 cycles to a complete metabolic remission on PET-CT scan at the end of last year. He then presented back with rash and skin lesions, one of which has been biopsied, as well as sort of bilateral pleural effusions and some, well, I understand some borderline lymphadenopathy on the CT scan. So just wondering, because he has had the skin biopsy. I think he's also had a lymph node biopsy, but he had that a bit later, so I'm not sure if you've got that.
Okay.
Oh God, I'm really sorry. I just saw this. This is the older biopsy from last year. I'm terribly sorry. I haven't got the most recent biopsy. My fault.
Okay. Jenny, can we defer? Is that okay?
Yeah, that's
fine. Apologies.
From a radiology point of view, Louise, is there anything to flag between now and next week, or?
He had, just to say with the radiology, he had a flu and a chest infection at the time of the scan, I think.
Right. Okay. Nothing to flag. That's hyper urgent.
So let's
review next week.
Yeah, let's review with the biopsy. Okay, thank you. Judith Chakachen.
This is, so sorry, Rachel's off sick and she's got a few on. I think this is a lady who's in her clinic next week to be seen. Someone with an inguinal node mass. I think there's probably imaging and a biopsy.
Okay.
Might test that. Let me have a look.
Yeah, so 69 with a nodal mass, type 2 diabetes, but otherwise in good nick. So yeah, there should be hopefully a node Dan, have you got one?
I do for this one, yes. It's a left inguinal lymph node for Judith Chakachen, which is cyclin D1 positive. It's a classical follicular lymphoma with aberrant cyclin D1 expression, and this has been requested. But otherwise, the phenotype is typical for follicular lymphoma with expression of BCL2, CD10, and the morphology is right.
It's interesting. How often do you see cyclin D1 in follicular?
Very rarely, but it is well described. Yeah, but it is very rare.
And imaging?
Yeah, so I've got the CT scan from the 18th of March. It shows a left inguinal lymph node measuring 38 by 26 millimeters, and then there's just smaller volume nodes in the up the iliac chain, measuring up to kind of 21 by 19 millimeters. The spleen's the one. There's nothing above the diaphragm, so it's stage 2 disease.
Stage 2, but going quite a long way up. Is that fair to say?
Yeah. So I think the most kind of superior extent is about here. So craniocaudally.
Yeah.
Right, 30 centimeters. Yeah.
Okay. I guess it depends whether she's got symptoms from the lump or not, but probably would be for active observation. I'd have thought. I mean, David, I presume that's a quite extensive stage 2 disease, isn't it? I presume you'd be happy for us to observe here.
Yeah, I mean, it's treatable.
Yeah.
But it would be a very long field, and a chance of having disease elsewhere is going to be quite high.
Very high, yeah. I'd personally be happy in a 70-year-old to observe here. Okay, thanks. I guess you could, if she's got just symptoms from the lump, a bit of low-dose radiotherapy might be reasonable. But I guess Rachel can talk about that with her. Okay, the next one's Susan Demant.
Thanks. I just met her today in clinic. So she's 61. She had a lung transplant in 2004 and then again in 2017. She's on azathioprine, cyclosporin and pred. She has CKD secondary to post-transplant issues, so an EGFR of in the sort of mid-30s. She presented to the surgeons with bowel obstruction and weight loss, had a laparotomy about, I think, just under 4 weeks ago, which has been reported locally, of a mass which has been reported locally as diffuse large B. And she had a PET scan at the weekend. So if we could review both, please.
Okay, thank you. So Dan, is this a monomorphic PTLD? Or?
Yes, for Susan Demant, we had a distending colon and small intestinal tumour. I confess I knew nothing of that transplant history. Nothing was on the request form. So it's an EBV positive high-grade B-cell lymphoma, so entirely keeping with a PTLD with strong EBV expression.
Just like to keep you on your toes, Dan.
Thank you very much.
Don't want to make your days boring, just sort of spice things up a bit. Okay, so let's have a look at the imaging.
Thanks. So I've got the PET across the top and the kind of baseline imaging pre-op at the bottom. So that showed small bowel dilated and thickened in March 2024. And then the PET now shows that there is a node above the diaphragm in right level 5, and then which is avid, and then several retroperitoneal nodes and nodules seen on the left and also on the right, measuring up to 27 by 20, maximum SUV 22.3.
Okay, thanks. But not actually from a volume-wise point of view, too much disease. So would you be happy to give single-agent Ritux initially? It sounds like if she's had some pretty major abdominal surgery recently and is recovering and so forth, and there's not loads of disease, that might be a reasonable standpoint.
Sounds like a good option, and talk to Herfield about her immunosuppression, I guess.
Yeah, I mean, yeah, absolutely. Reduced immune suppression. But yeah, I'd give I'd give some.
Thank you.
Give some rituximab monotherapy first, and then repeat the PET.
Great, thanks very much.
Okay. All right. So
the next patient is having his PET now. and there's,
Okay.
so there's no images taken yet.
Gregory,
defer.
yeah, we need to defer that, don't we?
That's fine, thanks.
Okay, still see Stephen De Silva.
Thanks, Toby. Mine, he presented with a left testicular diffuse large B and para-aortic disease. He's had 6 polar R chips, CNS prophylaxis is starting now with the IV section, and he's booked with David for radiotherapy to the scrotum once that's completed. But he's had a kind of end of treatment PET CT. I think David was just checking that the para-aortic mass was in remission and that we're happy to stick to the plan.
Sure. Louise?
Yeah, so it's significantly improved and it's CMR Doble 3.
Lovely. Thank you very much.
Great. Okay, good news. And the next one is Paul Nib.
Yeah. So he's a chap, I think we provisionally discussed him last week.
Mm-hmm.
How old is he? 73. He's actually very fit and well. I met him in clinic this week. He's presented with a rapidly, or quite rapidly, enlarging swelling behind his left mastoid, which is causing quite a lot of discomfort. It's been biopsied. I think we reviewed it last week. It looked like diffuse large B cell, but I think subsequently he's come back as double hit. And I think we were just going to rediscuss treatment options.
Yeah, okay. Have you given him any treatment so far?
Not yet. No, I just met him on Monday.
Yeah, okay.
Well, it's
Okay.
steroids now. Yeah.
Yeah, no, it's fine. Okay. So Dan, can you confirm that?
Yes, absolutely right. Originally reported as being a diffuse large B-cell lymphoma of the GCB type, and we do indeed have evidence of a MYC and BCL2 rearrangement.
Mm-hmm. Okay. All right. And remind me, imaging?
Yeah, we saw this last year. So he has an infraauricular mass on the left, which involves his parotid SUV max of 20.5, and he's got a number of other nodes that are avid, including hilar nodes, and also within his mesentery with some infiltrates. He's a chap who's had changes in his mesentery going back a long time, so about 2015. But now they're FTG avid. SUV max is 16.5.
Yeah, okay. Thank you. So do you think he's sort of fit for
He has, I mean, there is nothing objectively that makes him unfit other than the fact that he's 73. He's on a bit of allopurinol and some lansoprazole, that's a lot.
So I know we've slightly sort of switched back and forth our views on double hit lymphomas. I think current thinking is probably we would escalate to dose adjusted EPOC for double hit lymphomas. So yeah,
he's up for it. We spoke to him about it, and he's up for it. Would you go in at the normal, the straightforward doses? You wouldn't go for a dose reduction given age to kick off?
I think if he's in good nick with normal blood counts and he's 73, I
Just go straight in.
yeah, probably.
See what we get to. Okay, fine.
Yeah. Okay. All right. Next one is Elizabeth Macy.
Also looks like it's got Rachel's name. I don't think she's had the PET scan.
So this looks this a Hodgkin's. I'm not sure.
Yeah,
if
she's
they
a
had
61-year-old who presented with 6-week history of axillary lymphadenopathy, occasional mild night sweats. It's to review her biopsy and PET scan.
Yeah, okay.
Her PET is tomorrow.
Yes.
Okay.
Defer to next week.
If you're happy to, I think so. Pet's pretty important here. So yeah. Yeah. If she's early stage, we've got a trial, haven't we, Graham? I don't know if we're taking regional patients for the study. But...
Sorry,
anyway.
Toby. Which histology?
It's Hodgkin's, Graham, of course.
Oh, Hodgkin's. So at the moment, sorry, I beg your pardon. At the moment, we actually don't have a trial open to recruit at least for. Oh, this is early stage. Sorry, this is radar.
Well, no, we don't know yet. But I'm just saying, if it is,
I don't think we could. I don't think we could take regional for a first line study. I'm sorry, just capacity.
No, it's fine. Yeah, sure.
Because she's also been diagnosed or undergoing investigations for an abnormal cervical smear and possible.
Okay.
PA.
Well, let's review next week and yeah, go from there.
Thank you.
Okay, fine. And then Ian Henderson is next.
So I met this man a month ago and sent him off on his investigations for systemic malaise, mild anemia, IgM paraprotein. Unfortunately, since that, and he's got long-standing poor mobility due to cervical myelopathy.
Mm-hmm.
And he's got quite an interesting history. He's a famous bass player, so he's led quite an interesting lifestyle, I think. But anyway, unfortunately, he's now been admitted with pneumonia, and I hear from the ward team that he's deteriorating and unlikely to pull through now. So if we could just briefly review the histology and that confirm a diagnosis of LPL, but he's not currently fit for treatment.
What band was he in?
I think he's session based, so you know, Deep Purple, yeah, you name it, he played for them.
Oh wow, okay, fair enough.
Founder of God's Own Guitars. I'm just having a look now.
Yeah, I was rapidly googling at the same time. But you say he's not in great shape now.
I haven't. If any of the ward team have reviewed him, they could present.
Okay, have we got imaging?
Yeah, he had a PET CT on the 3rd of April. So he had some mediastinal lymphadenopathy, he had a paratracheal node in there, and then just scattered sub-centimetre nodes. And his nodes are only faintly FDG avid. His spleen and his marrow are also mildly show mildly increased uptake. So this could all be reactive or represent a low-grade infiltration. No suggestion of high grade on his imaging.
Thank you.
Okay. Dan apparently is struggling to rejoin. Have we? What does the local pathology say?
Well, he had a Trefine, I think, which would have gone straight to you guys.
Okay. Okay. Yeah. So you haven't seen it. Dan's internet's just crashed, I think, or his computer has, and he's coming back. Have you seen a report?
On the call, incidentally, if you
Gareth, this has saved the day.
Well, I was only on because I wanted to hear about Mr. Underhill, but if Dan's offline, the marrow shows about 30% kappa, light chain restricted, low grade B, in keeping with LPL MZL.
Thank you very much.
And the mid-88 was requested on the aspirate, but it's probably not
That's
needed.
enough then. Thank you.
So he's brilliant. Thank you. It's not like heavily infiltrated. Do you think the anemia is sort of due to other things at the moment, or
quite probably? So I think if he pulls
Right.
through this chest infection, we'll decide about treatment.
we can rediscuss and maybe a sort of DRC, something like that as appropriate. Okay.
Thank you.
All right. Thank you. That's very helpful. Okay, and then Christopher James is the last one. So
we added Matthew Underhill yesterday as well.
Yeah. Discuss Christopher James first. Is that all right?
Yeah. Yeah.
There is a pro forma, Toby, for that one. It was emailed separately.
Okay. Try and find it. But yeah, do you want to?
Yeah, Christopher James, another patient of Rachel's, who I met earlier this week, 74-year-old. I think he's had mantle cell lymphoma treated, just once, with rituximab and benzimustine, 6 cycles in May 2022, and then had just completed his last dose of maintenance rituximab earlier this month. Anyway, but since February, he's had a lesion on his scalp, which has been gradually increasing in size. And so we're hoping to review a biopsy.
So he had 2 years of maintenance. Do you say?
Yeah, sounds like it. May 2022 to April 2022.
Yeah. Okay. All right. Dan or Gareth, if you're still there. I don't know if you've got a biopsy for this guy.
Yes. There is a scalp biopsy, which shows basically relapsed, rather high-grade looking mantle cell lymphoma over the left parietal area, with acoustics still about 90%. So in contrast to the previous, which was sort of classical morphological invariant, this looks more blastoid, and a repeat TB53 has been requested.
Yeah, okay. Nasty. All right. Nia?
Yeah, and this is it here. It's about 6 centimetres in the left parietal region, and there's no underlying bone erosion, and there is nothing anywhere else.
Okay. And he's been imaged systemically, has he?
He has, yes.
Yeah. Okay. I guess you've got. It depends whether you call radiotherapy a sort of formal line of therapy. I don't think it would count from an access to ibrutinib point of view. You could, in theory, I guess, David, give some palliative radiotherapy here. I'm not sure how, if he's got really quite aggressive disease, I'm not sure how long it will hold him for. I guess he'll probably pop up with disease elsewhere very quickly.
He did have, just as he started at arbendomustine the first time, I think he went off to the Harefield to have a cabbage for vessel disease. So it's just that cardiac history in the background as well.
Okay. I don't know if David, you wanted to comment here. I guess the other option is just to go straight to ibrutinib.
Yeah, I mean, like you say, it might respond to radiotherapy, but how long it will respond for is the question.
It's growing quite quickly. I would say it's that scan is now closer to 10 centimetres across. So I wonder whether some radiotherapy to get, I don't know how quick you just get ibrutinib to.
I mean, they eat quite quickly. You'll get, I think if you started ibrutinib, you'll get some control reasonably quickly if it starts to work.
That would need a radical plan for radiotherapy if it's that big, so there'll be a 3-4 week running time even to get started.
Okay, that's helpful. So I'd start radiotherapy. Ibrutinib. We don't have a trial second line at the moment. Can I ask, is this guy a CAR-T candidate, do you think? I mean, should we be seeing him sort of pretty soon? Because, I mean, he's borderline pod 24 with a high Ki67 and blastoid histology. The ibrutinib's not going to last for long. So we need to be thinking about next steps.
Sorry, I've only met the ones. There were a few memory-ish concerns. So I'm not sure cognitively he's...
Don't worry, CAR-T will make that better, I'm sure. Absolutely, 100%. Make him loads better from that point of view. All right.
Cardiac history, I don't know. Was that exclusion?
Sounds like a good one for your trial, Toby. But...
Yeah, maybe. So I wonder whether, just sign here. I wonder whether you guys could maybe start him off and talk about sort of next steps, because I'd expect him sort of medium PFS of sort of 6 months here at best on the ibrutinib, and so third line treatment is sort of decisions about CAR-T or something else is quite important. But we could see him. We've got a trial open that he may be appropriate for third line if he's not CAR-T suitable as well. I guess we can talk about options.
And radiotherapy and possibly a referral to see you guys.
I mean, I would just crack on with the ibrutinib and use radiotherapy if he's sort of got unresponsive disease. Probably that's what I think I'd do. Yeah. Okay. All right. And then you've got someone called Matthew Underhill.
Yes. So this is a 21-year-old that we're treating for HLH, but I'll start at the beginning. So he presented on the 9th of April with a 2-week history of fevers, night sweats, rigors, had some, I think, doxycycline from the GP for a possible tonsillitis. On presentation, he had submandibular and occipital lymphadenopathy, was thought to have mumps, and then discharged, having had IV antibiotics for a day with 10 days of Pen-V. He represented on the 9th of April due to GP finding hyponatremia of 108 just on repeat bloods because he was still feeling poorly. On representation, he was hypertensive, systolic of 90, heart rate in the 150s, and was promptly taken to ITU. So initially being treated as sort of infectious mononucleosis with maybe bacterial infection. However, someone had done a ferritin at him on presentation. I'm not sure why they'd done it, but it was over 40,000, which triggered us into thinking about HLH quite early. He had high triglycerides, he had 2 cytopenias, so HB 107, platelets 47, and we actually did his H-score pre doing a bone marrow biopsy, and it was about 60% likelihood. Did the bone marrow biopsy on him the next day, and we did find lots of hemophagocytosis on the bone marrow biopsy. And again, doing the H-score again, it came back at 99% probability. So on the second day, we started dexamethasone, 20 milligrams, and he was also started on IVIG. He was discussed with UCLH, who suggested anakinra. So third day, he was on anakinra, 200 milligrams IVBD started. All of this time, he's on tazocin for sort of potential infection. He was initially a bit confused, and his delirium got worse over the next couple of days. And on the 15th, which I think was a Sunday, he had a seizure. At this time, microbiology were quite keen to start high-dose acyclovir, 800 milligrams TDS, and he was on fungal prophylaxis with amphotericin as well, just in case. I believe his delirium has much improved since then. To add to all of this, on his CT imaging, he had predictable splenomegaly, but quite large at 25 centimeters, and he had some lymphadenopathy, I think, in the axilla and also in his iliac sort of region. So he had supraclavicular lymph node biopsied, and I think preliminary results that we got yesterday suggested maybe Hodgkin's and Reed-Sternberg-like cells. At the moment, his current issues is a level of delirium. We did discuss with UCLH, and they think this is all driven by probably multifactorial sort of sepsis, hyponatremia that's resolving, 128 recently, rather than anything direct, and that he didn't need an LP. His other issues, worsening liver function, so ALP in the 600s and ALT in the 500s. We've not really got an explanation for why his liver function's worsening, other than maybe HLH itself. And if he was to have further chemotherapy, if he was going to have chemotherapy, then that may or may not be an issue. UCL didn't seem to think, they weren't worried about the liver function. They said go ahead with the etoposide at least. So that's where we are. His EBV was positive, and his copy number was 452,000 copies on his PCR. His CMV serology was positive, but CMV PCR was negative, and we think the CMV serology was just cross-reactivity.
Okay.
So we've got a supraclavicular node, Toby, to review, and CT.
Okay, so in summary, you've got somebody with a young man with high EBV titers and active HLH with CNS, sort of a CNS syndrome, and a node that you're a little bit worried about.
Just to add to the mix, Toby, he was on azathioprine for Crohn's disease.
Yeah,
as
sure.
well. So
And you've given him steroids and etoposide so far.
No, steroids, IVIG, anakinra. Etoposide been on standby, but I mean, clinically he's better.
But no rituximab yet?
Oh, sorry, it has rituximab, yes.
Friday.
Yes.
I was going to ask, yeah, okay. All right. Dan, what do you think of the node?
Yes, thank you. This is fantastic history. Thank you very much. So Matthew Underhill, we had a biopsy from a left cervical lymph node, and it's a good core biopsy which shows a very polymorphous population of mixture of atypical cells, which are a mixture of B and T cells, a few scattered HRS-like cells which are weakly CD30, and there's focal necrosis, and there's quite strong EBV. Absolutely classical for florid IM. So this is not diagnostic of lymphoma, and that fits beautifully. So thank you very much.
Yeah. So how's he gone with the? He's had a lot of treatment for HLH so far. How's he got on?
He's getting better clinically. They're keen to get him off ITU, actually, step him down. What's not? I mean, the CRP's come right down. Ferritin, we're still getting readings of over 40,000. So not accurate measurements on that front. Fibrinogen is about the same. Platelets are coming up. Hemoglobin's not improving. This, I mean, he's more lucid as well, according to the ITU team.
Yeah.
He definitely is really. I popped in to see him last night before I went home. He was markedly improved compared to Sunday.
Yeah, I mean, you know, with pucker HLH, occasionally you do see this sort of CNS sort of syndrome that just, you know, just gets better without any sort of, you know, obviously sort of focal disease or infection otherwise, so to speak. Yeah, I mean, obviously interested in what others think. I mean, I think the key agent here actually is I'd probably make sure he gets weekly rituximab at least for now, and yeah, I mean,
repeat viral loads, Tony, or would you just give him 4 doses?
I think he's ill, isn't he? I'd give him 4 doses and see how you get on. I'd give 4 weekly doses and see how you go. I'd probably keep him on steroids. I guess we could debate whether you should be giving him more etoposide. I think if he's getting better, I think I'd give him steroids and rituximab and sort of watch him closely. Is he still on the anakinra?
We reduced the dose. We sort of cranked it up to 300 BD, and now, as of yesterday, we dropped it down. His liver test starts maybe starting to improve a little bit, but still bilirubin of 284.
Yeah, and there's no sort of background history of odd sort of immunosuppressive disorder. I guess he's got Crohn's, hasn't he? And but there's no other sort of odd sort of background history of chronic infection or anything like that. No.
I think UCLH went after his genetic tests, haven't they?
Yeah, we've sent them.
Yeah. I think that's what I do. I think if you think he's getting better, I'd probably hold up. He's in his early 20s. I wouldn't give him any more etoposide than he sort of needs necessarily. But yeah, what do others think? Graham?
So are we absolutely certain this isn't
I don't think this
Hodgkin's
is
then?
yeah.
Okay.
This is not Hodgkin's, no.
Okay.
I
I
agree,
with
Toby.
EBV.
Yeah.
Have you got?
If he's getting better.
What do the infectious disease team say as well? I mean,
So the infectious disease team, because of the necrotic lymph node on one of his scans in the iliac region, were more concerned about TB, and he's had a T-spot done pre-azathioprine that was negative, and we were repeating a TB screen, but he's white British, never really been out of the country, so...
I guess
we had a case just like that. White
happens.
British from Banbury, TB, died because we thought it was T-cell lymphoma. So yeah, be careful.
but Graham, this guy's not from Banbury.
No.
I guess I think it's highly unlikely to be. I think this is the likely cause. I guess I ask because this is an infectious.
There were no granulomas presumably on the lymph node.
This is a reactive phenomenon due to an infection, right? So they may want to sort of be involved. But that's what I would do. I'd give him more rituximab and steroids, and probably hold off the etoposide unless he really starts to flare again and becomes unwell, and wean the anakinra gradually as accordingly, to his clinical sort of path. Yeah, so I think that's what I do. And then yeah, I don't think it doesn't sound like he's got any CNS problems. Nia, was there anything on the imaging that was particularly? Can we look at his?
No, I think we've heard everything. So his spleen craniocaudally was 19 and a half. His liver's a bit big, 25 centimeters. It's not a great scan because he's very skinny and the dose is pretty low. But he does have nodes in his axilla. He's got multiple nodes, but they are only just reaching size significance. He's got larger nodes in his abdomen and pelvis, including some of these nodes here. They're a bit low attenuation. I'm not sure they're definitely necrotic. He's had a bit of free fluid, had an effusion, yeah, and that's about it.
Okay, thank you. Yeah, quite a case. All right.
Sorry, one more. Sorry, it's David Newton. He was deferred last week, but doesn't seem to have made it onto the list. I'm sorry about that.
Okay.
Does that? Do you want an NHS number for him or anything? He had a supraclavicular lymph node biopsy. The NHS number is 454 427 4966. It was just to review his lymph node biopsy and the PET. He is a gentleman with previous diffuse large B-cell lymphoma who achieved CMR in 2018 after R-CHOP. However, he's represented with pancytopenia. His initial bone marrow maybe looked low grade and wasn't conclusive. You asked for a rib biopsy, which our IR team could not do, but they did a supraclavicular lymph node biopsy, which was equally avid as the ribs.
He's to say that the biopsy is with us, but it's not ready, so you probably need to defer this.
Okay, fine. Okay. Wally.
So if you could maybe just check with the MDT coordinator that they're definitely on for next week. That'd be great. Yeah, but I think
Thank you.
We need the biopsy, don't we? Okay, thanks very much, guys. Have a good week.
Okay, so Milton Keynes next, I think. Is Milton? Oh, there's Moes. Hi, Moes.
Hi, Graham.
Oh, Moes, you've just reminded me. I didn't get back to you about Andrew, did I?
That's fine. Don't worry.
I will.
Yeah, I've organised a pet, basically.
Okay. Oh, hold your breath. Okay, so I think for you guys, the first patient on the list we've got is Frederick da Costa.
I don't know if that is.
Yeah, it's my.
One of Sarah's.
It's my patient. I saw him today, but he has been referred from the general meds with ITP, but he found to have left supraclavicular enlarged lymph node about 2 centimeter, which was pathological radiologically, and he had a biopsy done, which locally reported as query LPD with CD30, CD5 positives, but they were not able to tell exactly, sent to Oxford for immune stain. He's 78, he's reasonably fit and well, but medical history of high blood pressure and diabetes, 6 months history of severe tiredness, some weight loss, and presented with ITP platelet count of 1, had a pulse of steroids mid-March, and then had a biopsy on the 20th of March, and had a CT scan which only showed localized left supraclavicular lymph node, no other lymphadenopathy or splenomegaly. So yeah, we just need to discuss if there is any update about his biopsy and the scan.
Okay, thank you.
Graham, this is one of the 3 MK patients for which I don't have any imaging.
Okay. Should we go to Dan for pathology?
Yeah, sure, of course. So Frederick da Costa, we have a biopsy from a left supraclavicular lymph node, which confirms classical Hodgkin lymphoma.
Okay. So sorry, no imaging, Sarah, but confirm the pathology. Have you got a sort of local report from a CT or anything like that?
Yeah, so the local report is just supraclavicular lymphadenopathy, nothing else on the local report.
Okay, and he's a sort of reasonably fit guy?
He's reasonably fit.
Yeah, a bit of diabetes. Okay, so I mean, I'd probably get a PET. Well, I would get a PET.
Yeah.
And, you know, in a 78-year-old reasonably fit, definitely also worth getting an echo, but assuming he's anthracycline fit, I would probably give AVD. Now, the exact number of cycles depends on, you know, the stage, but you would definitely also want, you know, if he's localized as well, I would definitely try and include radiotherapy in that, in a man of that age. So either sort of 2, 3 or 4 cycles and then radiotherapy, but we should probably have a look at the PET when it's done.
Yeah, we'll arrange urgent PETs and echo. I think he's got a lot of, he's on aspirin as a primary prophylaxis, but he doesn't have any heart disease, but he's hypertensive, obviously old, and diabetes with a lot of medications as well for both.
Yeah.
So yeah, definitely echo. And then shall I bring it back to the MDT?
I think so. I think it's worth doing,
with the PET, yeah.
Particularly with the radiotherapy.
He's reasonably well, and his platelet has completely recovered, so I don't think there is quite urgency to start any treatment. But yeah. Thank you.
Okay, thank you. Neil Hazel.
Yeah, he's mine. I think he's somebody with a localized diffuse large B, IPI2, age 61, high LDH.
Yeah, tonsillar mass. Okay. Dan.
Yes, so Neil Hazel with a biopsy from the 11th of March, from a left tonsil, which indeed confirms diffuse large B-cell lymphoma of GC type, and this shows no evidence of a Mickery arrangement.
Okay, and the imaging?
Yeah, pretty much the same. He's got a left tonsillar mass SUV max of 22.4, and then he's got ipsilateral left level 2 node SUV max of 15.3. Nothing outside his neck or oropharynx.
Okay. And sorry, Mose, did you say the IPI is 0? Or
Two.
Oh, right.
Yeah, 861, LDH 400.
Okay. I mean, it's still pretty localized, isn't it? So, I mean, you've put on the form, and I think it's very reasonable, R-CHOP with radiotherapy. Yeah, I mean, 3 R-CHOPs and radiotherapy, I think, would be very reasonable. You could do 4 R-CHOPs and stop still potentially, although the trial that did that in the over 60s did an interim PET after 2. But let me just ask David and Catherine's view on 3 R-CHOPs and radiotherapy.
I think that'd be very reasonable, yeah.
Yeah, should we go for that then, Mose, if you're happy with that?
It's the traditional approach, isn't it? He's not a super low risk one. So
Yeah.
I think it's probably
I'm always nervous about emitting radiotherapy.
I know you are, yes. I know the exact case you're referring to. I still maintain that had nothing to do with his relapse, but
despite we did the right thing.
Yeah,
anyway.
Despite what our Lincolnshire friend said. But anyway, David Lafford.
I think he's severe, I think.
There's a bit.
Don't know whether we should do him, Graham. Is it this guy with dementia with
Yes, this is the guy with dementia. Sorry, I thought one of the registrars would present him. So he's an 85-year-old man with diabetes, hypertension. He's got quite marked dementia, and his daughter has power of attorney for his health. He presented with weight loss and a GI bleed. Then had an OGD, and the biopsies have confirmed a high-grade lymphoma. So there are lots of discussions as to whether he should have, or whether the family wants him to be treated or not. He currently has bilateral keys and pneumonia anyway, so the infection needs to be treated before he starts any treatment, but there's a chance that he might just go down the palliative route. The family have had discussions with the team yesterday and are thinking about things. So I think there is a biopsy and a CT scan.
Let's go to Dan first with the biopsy.
Yeah, sure. So David Lafford, we had a biopsy from the 5th of April, a gastric biopsy, which indeed confirms a diffuse large B-cell lymphoma of non-GCB type.
Yeah. And Nia, is this another one without imaging?
It is, yeah. I don't have his scan.
Yeah, I mean, in a way, it's sort of academic, isn't it? In that we know it's at the stomach. I guess it could be 1E, but it's perhaps more likely to be more generalised. I mean, I think the whole thing of treatment or not. I mean, whilst it says on the form heart failure with preserved ejection fraction, I have to say with a history of AS, so aortic stenosis and heart failure, irrespective of the ejection fraction, I wouldn't be going near an anthracycline. It's one of the.
He's very frail.
Yeah, no, exactly. So, which is yet another reason, isn't it? So I think, the only potential sort of vaguely, the only combination chemo I would consider, I think, is RCVP. We have given that sometimes to frailer elderly patients. Yes, generally speaking, we don't think it's curative in high grade. There probably is a very small number of patients who are cured with high grade with RCVP. But yeah, I mean, I'm sure you've had this discussion, but I'm often saying to patients in this setting, we could do more harm than good quite easily by giving any chemo at all. So I think that's the sort of conversation between you and the person with the power of attorney, but I wouldn't go any stronger than RCVP.
Thank you.
So then we've got Raymond Loca.
Yeah, he's a mantle cell treated with R-CHOP, I think, ×6, and this should be, if I'm not wrong, end of treatment scan, I think.
Okay, thank you. Nia.
Yeah, so this was him at baseline. He had very extensive disease. He had a lesion in his oropharynx from his tongue base, nodal disease above and below the diaphragm, and this large mediastinal mass completely occluding his left main bronchus with complete collapse of his left lung. He had very large upper abdominal nodal mass, and then he also had some foci. He had splenic disease. He had some terminal ileum disease, which is probably in there, and some peritoneal deposits. And he's had a CMR Deauville 4, so he's had a reduction in all sites of disease with just faint uptake just above liver in his mediastinum, at that site of bulk in his upper abdomen, and in the region of his terminal ileum. His spleen was 18 centimetres cranial-caudal, and now it's 9.5.
Great, thank you. And it was P53 wild type at diagnosis, wasn't he? So, yeah, I mean, I think maintenance rituximab, Mose, is what you've suggested.
Yeah.
Completely agree. Yeah. Sounds good. So then we've got Constance Nolan.
Yeah, she's a low-grade lymphoma who's been followed up by MAGS for a number of years, and then she's got admitted with quite unwell with an abdominal mass, and there should be some. I'm hoping there's some imaging to review and a lymph node biopsy to review as well.
Biopsy is pending, but it's not ready yet, I'm afraid.
Okay.
Yeah, I don't have her scan.
Okay, it's disappointing. Okay, should we put her on off till next week then?
Yeah. Thank you. It might be worth. Do you have an MDT coordinator your end, or is it just you guys sending us the forms?
No, we do.
You do. It'll just be worth your MDT coordinator your end reminding, because we don't. Our MDT coordinator's off this week, so I'm worried that the deferrals won't sort of be remembered. So do highlight them next week if that's okay. Alison Sandaver.
So follicular lymphoma diagnosed about 2.5 years ago now, I think, and treated on Patria with R-bendamustine ×6 to complete to CR, and then represented about 2 or 3 months ago now with recurrent neuropathic symptoms down her arm, and had a biopsy which was consistent with relapsed follicular lymphoma, and she's discussed amongst us, and the options of R-CHOP versus EPCOR versus trial were discussed. She's opted to have R-CHOP. She's had 2 cycles of R-CHOP and then got admitted about 10 days ago with recurrent neuropathic symptoms down her hand. So there was concerns about her response. So she's had another MRI scan. So it'd be just nice to review that and to confirm we're going in the right direction.
Thank you. Nia.
Yeah, so it's an MR spine, but you can see her sites of disease on it. So she had a left level 4 node, she had posterior mediastinal disease, she had splenic disease, and then retrocrural and abdominal disease, and also renal disease. So her left level 4 node is reduced in size, so it's that, compared with, on the CT component, it was that before. Let me just see if I can get the right sequences. In terms of her renal disease, not that one. So obviously it's an axial to look at the spine, but you can already see that compared, looking around her aortic cable region and the lower pole of her right kidney, looks like she's already had a good response. And her posterior mediastinal disease as well, you can also see that she's had improvement. So yeah, this is just a tiny bit of residuum probably just in there actually. So she looks like she's had a good partial response already.
Great, so nothing to explain the symptoms, the neuropathic symptoms.
No, I mean, she's got a little bit of cervical spondylosis, a little bit of a straightened spine. I mean, I don't know if her original symptoms were due to this level 4 node. It's sort of in the region of her brachial plexus, but nothing new, no.
Yeah, she's got a few symptoms in her legs as well, so I just wondered whether it could be vincristine. So, because she's had such a good response, I've just dose reduced vincristine a little bit now, from now onwards.
Sounds good. Good, phew. Okay, thanks, Mose. So we'll continue with the plan, heading for an autograft. I think that's is that your cases? I think it might be. Thanks very much.
Okay, thank you.
Cheers then. Okay.
Bye.
I don't know if our Swindon with us yet.
Hi Graham, it's Heather.
Oh, hi.
I am here. I don't know if anyone else is yet.
Me too, Sashi.
Great. Is it me or you, Toby? I can't remember. I'm happy to.
I think it's.
It's going to be me.
Oh, is it you, Dan? Maybe.
Is that okay?
Great.
Yeah.
Just a heads up, I don't have imaging for Joyce Collins. I'm not sure if it was, it was required, but I don't have it.
Sure. Okay. I think this is one of the John's patient. Should we start from the second patient then? I don't think John joined the line yet. Okay, so your second case is Christine Glasgow. Does anybody know this patient? It looks like it was referred from.
Claire, I think Claire's joining the call as well. Sorry, she's not on yet. She's Claire Davies' patient.
Okay, yeah. So and then we have two patients from Alex, and Sashi, you have a patient, Alan Pamford, right?
Yeah, I think it's going to be very straightforward. We discussed him before in previous MDT. He's a 62-year-old with a recent diagnosis of mantle cell lymphoma. He presented with upper respiratory tract symptoms, chronic, ongoing, and some sleep apnea, and had a biopsy from a postnasal thickening and MRI and the PET-CT showed a limited stage disease. So we considered offering him local radiotherapy versus active monitoring. Patient was keen to kind of take up the radiotherapy route. He had a trephine, a bone marrow biopsy to kind of further refine his stage of disease. It is the trephine biopsy to look at. Flow has come through saying a low level of BNHL, but not typical for MCL in their flow markers. So it's just to kind of clarify whether he has the dual pathology or whether this is the same MCL stage 4. Thank you.
Yes, so for Alan Penfold, no, the trephine from the 5th of April is clear. There's no evidence of mantle cell lymphoma. And yes, we had the diagnostic sample from the end of February with confirmed MCL.
Sure. So it sounds like radiotherapy is a way to going forward, right?
Yeah, thank you
And
very
that's the
much.
plan.
Thank
No
you.
problem.
And we'll stick with the limited stage as well, isn't it? Yeah. Thank you.
Yeah, because the marrow is, not diagnostic for involvement. And I'm not sure whether, Heather, should we go for your case first while waiting for the others to join?
Okay, yeah, that's all right.
It's Sally Wharton.
Yeah, Sally Walton. So this is a 38-year-old lady who's got a short history, sort of 4 to 6 weeks of fevers, and was admitted very unwell with marked pancytopenia. She also had high ferritin and high triglycerides and fulfilled pretty much all the criteria for HLH. She was started on HLH treatment with anakinra and high-dose steroids, but didn't really improve with that. We should have a CT to review, an MRI of her orbits, because she has some lot of preceptal, what looked like a preceptal cellulitis of the right eye, and possibly some rectus muscle involvement, and she's also had a bone marrow trephine to review to discuss. I had actually spoken with Toby outside of the MDT last week when the bone marrow was suggestive of T-cell lymphoma, and she has had a first cycle of CHOEP with a really good clinical response so far. So if we could discuss the imaging, the marrow, and her ongoing plan, please.
Sure. Dan.
Yes, for Sally Walton, we have a trephine from the 3rd of April, trephine in which the normal hematopoietic tissue is replaced by a very atypical population of T cells with strong EBV infection. Given the atypia and the abnormal phenotype of the T cells with marked loss of CD5, the high proliferation index, and the EBV expression, this is entirely in keeping with an EBV positive T cell lymphoma, and PCR is pending.
Thank you. Should we have a look at imaging?
So you probably need a neuroradiologist if your opinion on these, but essentially she back on the 4th of April, she had some signal change in her right lateral rectus. It's non-specific. She then had a contrast enhanced study 4 days later, but I don't know if this was post steroids, because the inflammatory change she had in the periorbital region had improved. The lateral rectus was less bulky than previously, but she did have a little bit of residual inflammatory change in her post-septal orbit. The appearance is very non-specific. And then elsewhere on her CT, she had a 13.5 centimetre spleen, but her liver was big at 25.5 centimetres. And then elsewhere, she just had a little bit of free fluid, so some fluid adjacent to the lower pole of her kidney and tracking down her paracolic gutter into pelvis, and then a bit of interlobular septal thickening in her lungs, which may indicate a bit of fluid overload. No nodal disease to speak of.
Thank you. Thank you. So the HLH had improved after starting up the CHOAM.
Yeah, so she did nothing. The anakinra did nothing really, and the high dose steroids and IVIG. But since having the CHOEP, her liver function has improved. Her bilirubin's halved. She's not febrile anymore. So yes, I think we've done. She's still pancytopenic, I guess, as you would expect. But I think the chemo has done something. But obviously, it's how to keep it that way.
I suggest to continue with CHOAM in this case, right? Like for 6 cycles, and with aim for autologous stem cell transplant as a consolidation. I don't know what people think. Looks like aggressive lymphoma.
I think it's reasonable. The only thing I'd say is I think you could review the role of etoposide if the HLH is under control, sort of later down. If you're like down on cycle 3, 4, and she's clearly fine from that point of view, it's really added to control the HLH, right? So.
Yeah, and the report we got was from the pathology was of NK lymphoma. We were just wondering whether that would be any role of escalating to something with that.
Yeah, there's a lot of it around. Got a case of JR at the moment as well.
Everywhere.
Dan, is it reported as an NK lymphoma?
Yeah. So the bottom line report is actually called, it's been named an EBV positive NK T-cell lymphoma, which actually has a mixed phenotype. This particular tumour actually has some expression of CD3 as well as CD56 and some variable CD30. So it would fit the kind of nasal type, and would be the classical presentation of this kind of phenotype. So it's an appropriate designation of NK/T.
That does make it more interesting.
Yeah. So would that change what we're planning? So I suppose.
Well, I think it does. Yeah, I think it does. I'm just wondering, actually. I mean, she's 38, isn't she? I mean, I hate to say it, but I do wonder about SMILE. Yeah, I mean, it's the worst. It's the worst named regimen out there because people on it do not smile. But but you know, it's got etoposide in it. She's high risk CNS involvement, and there's lots of agents that get across the blood-brain barrier. I think I would. I mean, do you agree, Toby and Dan May? I mean, it's.
I agree. I mean, the data supporting its use in otherwise fit young patients is reasonably. It's pretty good. I would go for that.
And I'd also head for an allo in first remission. I mean, that's in this sort of setting. So I'd let the allo team know quite soon about it.
Yeah. So supposedly we will monitor the EBV PCR level as well, right?
That's quite good to do.
Yeah, we're doing that as well. It's not very high actually, which I heard is might be a good sign, but I think everything else is quite bad. But that we were wondering about that sort of escalation as well. So we'll tee that up when she's had a chance to recover from the CHOEP.
Yeah. Can I just ask that, is it because of the HLH would prefer SMILE rather than DDGP? Because I know that DDGP is what we normally do for
It's also the CNS risk. So, you know, the problem with GDP is there's just nothing, because DGP is just GDP with asparaginase, yeah. So for young, very high risk patients, for CNS risk, I think that's the main reason, I think, for doing it.
Yeah, okay.
Thanks, all. That's really helpful.
Yeah. Shall we go back to the top? Is John joining? Yes, the first patient, Joyce Collins. Does anybody know? Okay, because we don't have imaging and it's a CLL, doesn't sound like urgent to discuss. Should we defer it for a week?
Do you know if John's joining?
I think that's fine,
Yeah, sure. And the second patient is Christine Glass-Ankle.
Hello, yes. So we discussed her about 3 weeks ago. So she's a 79-year-old woman who presented at the beginning of March with neurological symptoms and found to have a frontal mass. Reviewed at NeuroOnchem-DT, she was put on steroids by the medical team pending that. She's 78, but previously entirely fit and well, and was possibly a goer for chemotherapy. And we talked about attenuated chemotherapy for her, and she was referred back for potential consideration of a biopsy. However, came back in about 2 weeks ago with increasing confusion, and had further imaging which didn't show, and then subsequent MRI which has been reviewed again at NeuroOnchem-DT, and they felt there wasn't a target to biopsy any longer. I mean, clinically, I don't actually think that she will be okay to go for chemotherapy any longer. There's quite a significant deterioration, though she has improved slightly going back on steroids. So my question was, do you think there might be a role for some palliative radiotherapy? She's currently on dexamethasone in hospital still.
Sure, thank you. Is she steroid responding?
Well, it's difficult. So the imaging, the NeuroOnchem-DT felt that there had been some improvement, and they felt there was no longer a target to biopsy.
Right.
Clinically,
Okay.
she probably has improved a bit on the steroids, yes.
Sure, thank you. Should we have a quick look at imaging, and then I can ask David and Catherine's opinion?
Yes, so this is her in March. She had multifocal enhancement in her right frontal lobe associated with some vasogenic edema. She didn't tolerate her subsequent scan very well at all. This is the post-contrast from the 3rd of April, so it's very difficult to see, but there looks like there's been a reduction in the enhancement. There may be a bit of tiny enhancement, but it's pretty much non-diagnostic. But the edema has improved. On the TT, you could make out a lesion there. It's very difficult to assess now, but the edema has improved, so she's had a significant improvement between the 2 scans.
So this suggested steroid responsive. David, Catherine, I know that you probably only consider this as a palliation treatment, and
yeah, I get increasingly nihilistic about using radiotherapy in some circumstances. We just had another failed attempt to try and give a patient benefit for a man in Oxford. So I'm probably not the best person to ask. It'd be interesting to hear what Catherine... the last one Catherine treated did really well, so maybe that's it. Maybe Catherine should treat them instead.
Thanks, David. Yeah, but I think we just have to see them, don't we, and see what they're like. If the performance status is improving on the steroid, we see them, talk to them about it, and hope that they don't deteriorate between that and actually delivering the treatment. So if she'd like an opinion, then happy to see and give it.
Okay, thank you.
It'll just be short.
Goes. Yeah, thank you.
Sure. Yeah. So, great. Thanks very much. And shall we move to your next patient? It's Adrian Lamford.
Yes, it should be fairly quick. So we've discussed him a few times. This is this man with this ALK negative CD30 positive anaplastic large T-cell lymphoma. They originally presented with skin disease, but also had some nodal disease as well. He initially went into CMR with BV-CHIP. He had an upfront beam autograft and all looked very good, and then unfortunately had a very quick skin relapse. And actually on his shoulder, he responded really well to GDP, but during treatment he developed further lesions on his leg, his left leg, and the plan was to refer him for radiotherapy. I think David actually saw him yesterday to plan him, but he never actually his leg CT petted, so we wanted to get that done. I'm not sure if you actually have that one, but it does show 3 areas essentially of avidity, 2 of which you can see when you examine him. There you go. And the one at the back you can't see. But at least according to the report, there are no other sites of disease on the repeat PET apart from the skin. The long-term plan is to refer him for allograft. And it's just having gem monotherapy, gemcitabine monotherapy at the moment.
Yeah, thank you. Yeah, shall we just have a video showing that?
Yeah, so essentially it,
yeah.
he back in December he had this large lesion overlying his scapula. He also had pulmonary disease, and he had hepatic disease, and he's had a CMR at all those Deauville 2 at all those sites, but as Alex said, he's got these 3 FDG avid lesions in his left lower leg. His prior PET-CT didn't cover this region, so we don't know if there was anything brewing at that stage, but yeah, he's got 3 lesions, SUV max of 24.
Thank you. So David, Catherine, you're happy to zap those 3 lesions with
radiotherapy? He was due to come yesterday for clinical planning, because when I saw him in clinic there was just a 1. So I'm slightly concerned that these new bits are popping up, but they're all still within a treatable area. So we switch from a clinical plan to a CT-based plan, and going to give that area of his leg 40 gray and hope for the best that nothing pops up elsewhere in the interim.
Sure.
Sounds sensible to me.
Thanks very much, those. Alex, shall we move to your next patient? I think we've done Sashi's patient. It's Charlie Branford.
Yeah, so Charles Bradford is a patient referred by the local gastroenterologist with lower abdominal discomfort. It's actually otherwise asymptomatic. He has a mesenteric mass that was biopsied. Locally, it was high-grade disease, but perhaps an underlying component of follicular lymphoma. He's relatively comorbid. He's in his 80s, atrial fibrillation, hypertension, and a stroke, although his performance status is actually pretty good.
Yeah, I think we discussed last week. We're just waiting to have a look of the PET, right?
Yeah, so I couldn't show the images last week, but here is his PET-CT. So he's got FDG avid nodal disease below the diaphragm, and then he has a large mesenteric mass, which is 12.5 by 6 centimeters, SUV of 8.5. The PET-CT report says no definite extra nodal disease, but actually on his diagnostic CT, he had quite marked peritoneal thickening in his pelvis, and this corresponds to that. So he's got FDG avid peritoneal disease. He's also got a mental infiltration on his diagnostic CT. So to my eye, that looks like he's got uptake there. I can show you, I can try and show you his CT if it'll load this time, which is a bit more convincing. But he looks like he's got stage 4 radiologically, so I slightly disagree with the external report. Oh, really doesn't like that CT. I've definitely seen it again today. There we are. So in his pelvis down here, this is peritoneal thickening that he has caudally, and that looks FDG avid. And then this is a mental disease as well, so stage 4.
Yeah, and can I ask what's the highest SUV?
18.5 in this large mesenteric mass.
Yeah. Do you think there's clinical evidence, like there's radiological evidence of high grade in the PET-CT?
Well, based on the fact he's got peritoneal and mental disease and a high SUV, I would probably say yes.
Yeah, sure. Because Alex, last week we discussed about whether it's for a CVT or mini CHOP. What do you think? Yeah.
I think we should try more mini CHOP, to be honest. Unfortunately, for some reason, I don't have an LDH, but it does look aggressive, doesn't it? So
Yeah.
that would make
Looks
sense to
quite
me.
bulky.
Yeah.
Okay.
Me too. Yeah.
Perfect. Yeah. Yeah. Sure. Okay. I believe that's all your cases.
I've just had a quick look at Joyce Collins, John's patient, and I don't think there is a CT. So could we discuss? I've got the performer. Is that
sure.
okay? Sorry
Yeah,
to come
of
back
course.
to for the confusion. So I've got the
No
performer.
problem.
So yeah, 82-year-old female with CLL since 2013, not treated. Had a recent rise in the white cell count. It's now 230, and hemoglobin and platelets have both fallen. So platelets are around 100, just over 100, and hemoglobin 104. She's had an ultrasound which shows a 17.4 centimetre spleen. As I said, there's no CT, but nothing clinically palpable. I think John's feeling is that she would need treatment for CLL. There's no kind of significant comorbidities. She's got high blood pressure and high cholesterol and gastroesophageal reflux, but no history of cardiac disease. So I don't think there is actually anything to look at. Oh no, sorry, there's a bone marrow to look at. Please, Dan.
Yes, of course. Just from the bone marrow from Joyce Collins on the 26th of March shows a 70 to 80% infiltrate of CLL with no evidence of high-grade disease.
Oh, thank you. Yeah. So basically, it's a developed progressive bone marrow failure, right? With heavy CLL infiltration. So it's 82, right?
Yeah.
I guess it's a discussion about BTK inhibitors and fixed duration with O+VAN. Probably, personally, I might more keen to do with BTK inhibitors, but I'm not sure whether John have anything in his mind already.
Not that I no preference, but we can take it back to the patient. So,
yeah, it's probably just to have a discussion with patients, really. Yeah. And have you sent the IGHV and TP53?
Not that I don't know the result, but I'll make sure that's
Sure. Yeah. I guess it's just it's TP53 is just make us more lean towards BTK inhibitors.
Yeah, she has had that. Looks like she has. And it was she did have a variant in the TP53, a deletion.
Right.
So yeah, sorry about
Yeah.
that.
Yeah. No problem.
Okay, thanks very much.
Yeah.
So we'll go for
No problem.
acalabrutinib then.
Yeah. Okay. I think that's all your cases, right?
Thank you.
Yeah. Thanks very much. Have a good week. Should we move back to Oxford or should we start with Reading?
Were there any Oxford ones left?
Sorry, yes, there are two,
Yeah, we have
which
two.
were sort of added on, but they are quite important actually. Can we just quickly do Alan McCulloch first, who I know Louise has prepped? He is a guy who is T-cell lymphoma. He's about 63. In fact, he is 63. And he had CHOP BV on a trial onto a PMR, really not a very good PMR. So he then had ICE ×3, and this is potentially a pre-auto PET. It's just his remission status basically, but he was quite refractory to CHOP, so I think we need to, check he's okay to go ahead. Thanks, Louise.
Yeah, so it's a bit tricky. So he had his PET in January 2024, where there was residual disease in a portocabal node seen here, and that's slightly improved. So SUV is now, right, so it hasn't been, it's not reported, but it looks visually like it's gotten better. And then there had been an indeterminate sacral lesion, which I think looks looks fine now. But there are a couple of new areas that are indeterminate. So one is the left axilla. So there are a few tiny avid nodes, but that was the injection arm. So that might just be injection. There are a couple of avid hilar nodes, and again, they're very, very tiny. You can barely see them on the CT component. So although they might represent early progression, I think it's very, very indeterminate. And then again, within the spleen, there had been a couple of tiny foci, and now they just look slightly more avid, but they're all below SUV max 5, or well, the most kind of avid one is 5.2. So it's been given a Deauville 4, and yeah, I think there's no definite progression.
Yeah, I think it's good enough. I mean, it's a bit dodgy, isn't it? But there's nothing definite, is there? So yeah, if everyone's happy for us to go ahead, he's all teed up, ready to come in next week. But and then a Reading here. No, so let's quickly, if we can, just discuss Lubo Zai. Many of us know him very well. Yeah, he had diffuse large B. He had relapse in his optic nerve. He had matrix ×4. He then had progression of a cerebellar lesion. He's extremely well asymptomatic from that cerebellar lesion. The ophthalmologists think he's actually progressing in the eye. Now the eye is gone. You know, he's never going to regain sight from the eye, but they are concerned that he's getting new retinal disease, same eye. So and he's been approved for CAR-T pending results for biopsy. He's got new paraduodenal nodes, so he's actually having an endoscopic biopsy. So I don't know if that's going to get the diagnosis, but if that does show high grade, he's then approved for CAR-T. The real question is, how do we bridge him? And David, I'm going to ask, well, and Catherine, can I ask your opinion? Because basically the abdominal disease, I mean, we can briefly look at the PET, is quite low volume, and he's asymptomatic from that. Obviously, we're a bit worried about the brain disease. He's got this cerebellar lesion and the eye lesions. Our question really, I think, is some sort of brain and eye radiotherapy a suitable bridge? Obviously, we'd just forget the abdominal disease in that case. The alternative for the eye is the ophthalmologists are happy to give intravitreal methotrexate, and we have seen responses with that even in matrix failure patients, at least with ocular disease. I think, Katerina, you were saying that Neil Evans, who's on the wards at the moment, he responded to intravitreal methotrexate, albeit that was vitreal disease, despite having not responded to matrix. So it's a really tough one, I think. But do you mind, Louise, just showing particularly David and Catherine the scans of the brain? And yeah, thank you.
Yeah, so I've got the MR brain from the 10th of March up here, and that was the cerebellar lesion, so 9 millimeters. Also avid on the PET. I'm just trying to find the ocular disease. So there was some, it's described as some soft, lentiform soft tissue.
It may be there's very little to see. It may be all ophthalmological.
Yeah, they basically said there's no pathological enhancement of the left optic nerve, and there was very little, and no change since November 23. And I can't really see, anything significant there. And there was no kind of avid focus on the PET on the Q-clear images once it had been windowed. So I think there might be, so if I reshare, there might be a tiny focus of avidity, just so these are the orbits and these are the muscles, and I think that is possibly a tiny focus of avidity within the fundus, whereas that is much more much easier to see that focus of avidity within the cerebellum. And
Yeah.
so, yes, whatever it is, it's very subtle.
Yeah, and I mean the alternative as well, which we're doing anyway, is just to give him some high dose Dex. I mean, we are going to give him 4 days after day after the biopsy. But David and Catherine, what's your thoughts? It's all very small volume, I know, but
Does he need?
Yeah. Well, that's what I was going to say. It's all small volume, perhaps even smaller volume there than in the abdomen.
yeah,
I mean, when we give brain radiotherapy for lymphoma, we tend to include the orbits anyway. So
yeah,
whole brain and eyes is not an unreasonable thing to do, but
yeah.
quite a toxic treatment for quite small volume disease.
It is. I mean, always in the back of our mind is this report, you know, I mean, there's not much data on it, but a report from ASH showing better outcomes in the absence of active CNS disease as opposed to inactive, i.e. people who did have it, but you know, obviously there's a spectrum, isn't there? Katerina, what are your thoughts on this?
Yeah, I think it's quite toxic for such low volume disease, but then I was just thinking we had similar low volume disease in Gregory Board, and then he developed all of this massive edema around the lesion. I was just thinking, could we do radiotherapy to the orbit and ibrutinib perhaps? Would that be an option for the brain, let's say, so we avoid the kind of, you know, brain toxicity? I don't know, is that something to consider?
The orbital disease is almost microscopic, isn't it? You need to be an ophthalmologist peering down there.
Okay.
Or we could take them up on their offer of doing intravitreal methotrexate and go for ibrutinib, because there is we can probably get compassionate use of ibrutinib. Because again, there is a bit of data, isn't there, suggesting reasonable outcomes with ibrutinib bridging. But yeah, I wonder if we go for that. Yeah, I mean, obviously we'd have to coordinate the eye injections with the ibrutinib, but okay. That's helpful. I mean, I know what you mean. It does seem a bit heavy hitting, doesn't it? Do the whole brain and orbits for such small volume disease. Okay, so if we perhaps say consider compassionate use of ibrutinib with intravitreal methotrexate, I think it would be good to get some control of disease in the eye, albeit it's very low volume. They can definitely see it when they do a slit lamp.
I'll email the company once we have the result of the biopsy, perhaps.
Oh, great! That'd be
definitely heading there. So we can do that.
Thanks, Katerina.
Thank you.
Okay. I think are Reading here?
Yes.
Great. Hi everyone. Okay, so I think we've got Henry Curtis.
Yeah.
Familiar name. Yeah.
Oh, it's Ash's patient. He asked me to present him, but he's sitting here.
He's a chap in mid-70s who you guys apparently did CAR T-cell therapy for, essentially got a refractory diffuse large B-cell lymphoma, and it literally presented with sort of disease around the spleen, sort of stomach area with a GI bleed, and then when he'd relapsed, he got a lump on the sort of right side of his chest wall, which was flipped through at a rapid rate of knots. And then he had that thing RGDP, which he didn't respond to. Then he had one R-bender code, then he had the CAR T. He had some residual avidity after the initial PET scan after the CAR T therapy. And this was a subsequent PET scan, I think about 3 months' time. I spoke to the radiologist after the initial PET scan, and they said that the lesion that was added on the PET at that point, they couldn't biopsy unless they went through the spleen, so it was a bit risky. And then he had an endoscopy done as well, I think a month or so ago, and that didn't show any sort of worrying lesions that were present when they did that. So it's just look at his PET scan, really.
And so it's 3 months, basically, is it, after the...
Actually, you can correct me.
Right.
Okay, so we've got the fuse PET on the right from September, the middles from November, and the one on the left is the current. And essentially, there just seems to be a residual focus of uptake, which extends just posterolaterally from the fundus into the spleen, which is probably better see on these fuse images on the right-hand side. And that avidity, as you can see here, still remains significantly above liver. So it's fairly suspicious for residual uptake. The previous sites of disease involved in the right lateral masses pretty much disappears, just a small area of fat stranding similar to the mediastinum, and there's no new sites of disease elsewhere. The spleen's okay and bone marrow's okay, so it's just really this focus.
But to my untrained eye, that looks a bit better.
It is better, but it's still above liver.
Yeah. Do you mind saying what the SUVs have gone from and to, just to get a sense?
Graham, there might be a PET scan from Oxford then, from about January, February time maybe. I thought we did one in between. So you had one, I think, recently, relatively soon after the CAR-T, and then this was the 3 month one, but there's an intervening one that's like that.
The month one is here.
So what are we looking at here? What's the middle one?
November.
Which was?
That's the pre-CAR.
That's pre-CAR. Okay.
Yeah,
so it's difficult, isn't it, when we don't have them on the same system? I don't know. I mean, we can't really review them. I mean, we can get them up, but I would think our radiologists are probably dialed off by now. Okay. Has he had radiotherapy to that site? Is that anything that's ever happened?
No, I don't think he has. Oh, he had some radiotherapy initially after the initial sort of treatment of the R-CHOP, but I can't remember exactly for that site. But he did have some.
Yeah, well, it was 30 grade for stomach consolidation.
Okay. Okay. Well, the optimist in me is thinking it's not blasting away in front of our eyes, because. So I think really, particularly if he's had radiotherapy to that site before, I would probably just suggest repeating a PET in, I don't know, maybe another 3 months, obviously to bring it forward if he gets any symptoms. Because at the moment it's looking like, I mean, it's a shame we can't compare them accurately, but it's looking a reasonably steady.
SUVs from the previous.
Problem with SUVs on different machines, though, I'm never sure if you can compare them properly, because what's the Reading uptake time, just out of interest? Do you know?
Should be 60 minutes.
Yeah, see, ours are always 90, so, you know, they're just not the same study, unfortunately. Okay. Well, look, I think with that, in a site of previous irradiation, a place where we can't easily biopsy, I think I would just say repeat the PET in probably 3 months, although slightly nervously saying that, but obviously I'll bring it forward if any new symptoms. Is that okay?
Yeah, that's fine. Thank you very much.
Okay.
And what Deauville would you say that is? Sorry, would you be able to give us a Deauville score?
6.2, so it's above liver, so it'd still be a Deauville 5.
D5, that's what we had here as well.
Well, would it be 4 or 5? Just to push you, because anything above liver is 4 is above liver as well, isn't it? It's just not wildly above liver.
Intensity, yeah, with the intensity above. I mean, they haven't actually. One sec, let me just have a quick look. Unfortunately, the report I've been given, they haven't actually written down the liver activity, but on the more optimistic side, if it's, you know, maybe just under 3 times, it might be DR4, DR5. I'd need the original alpha values for the liver.
Yeah.
Could you let us know, because I think it kind of does make a difference.
Yeah.
To us. Thank you.
Yeah.
Okay. Let's go to Christopher Dunn.
So this man's 77, and he noticed a left testicular lump of about 2 centimetres. Beginning of March, he went on to have an orchidectomy and a CT. He's not yet had a PET. He's pretty fit. He's still working part-time as a gardener until this happened, and just has high blood pressure really otherwise, which is not a big problem. So I think you should have the orchidectomy specimen there. And we've got the CT, which
Okay.
Yeah, the left testis for Christopher Dunn shows diffuse large B-cell lymphoma, which is non-GCB, and we have FISH pending.
Okay, and the imaging?
Yes, essentially the imaging from the 23rd of March is normal. There's no lymphadenopathy, no significant findings.
Okay. So I think, yeah, I mean, these are funny, these, aren't they? We tend to, even stage 1, recommend the whole works, you know, R-CHOP times 6, 2 ITs. We do still recommend ITs with testicular, 2 IV methotrexates and radiotherapy. Is he fit for that?
I think we'll have to see how we go.
Yeah.
Probably, but he's having to think about it already.
Yeah.
I feel like we might end up doing 4 ITs rather than.
Yeah, that's reasonable. That's reasonable. I mean, it's 77, so yeah, very reasonable. Yeah.
And have I got it right that you, unless the PET shows us we've got active disease now, he would not be eligible for polatuzumab for stage 1 and stage 2?
Yeah, I think that is correct because it'd only be IPI 1, wouldn't he? Over 70. I don't think you can call it stage 4 being in the testes. It'd be 1E.
Yeah, exactly.
Yeah.
Okay.
Okay, thank you. Now, Dan needs to go quite soon, and he's asked if we can jump down to the 4th case, which is Elizabeth Kington. Is that right, Dan?
That's right, yes. Thank you, Graham.
So Elizabeth is 30. She's a fracture liaison nurse in our trust and has one child who's now 7 months. She noticed adenopathy in the left neck, which is what we should have a biopsy of, and she's also had a PET scan. She's got pretty normal looking bloods.
Okay, Dan.
Yeah, thank you very much for accommodating me. So Elizabeth Kington, we have a core biopsy from a left supraclavicular lymph node, which is a good core biopsy, very sclerotic with nodules, which is very, very suspicious for classical Hodgkin lymphoma, but it's not diagnostic. So in my report, I've asked for nodal excision, but very, very suspicious this is Hodgkin's.
Okay, should we look at the imaging?
So this is the PET scan from just this month, and essentially they've got conglomerate FDG avid nodes extending along the anterior mediastinum on the left-hand side, measuring 10.3 centimeters in maximum diameter, with a smaller conglomerate area nodal mass on the right-hand side, measuring 6.29 centimeters. There's further avid nodes in the supraclavicular fossa, as you mentioned, with a smaller nodal volume on the right. Spleen, there's no nodes otherwise else above the diaphragm. Below the diaphragm, there's a 2 centimeter fairly avid node, as well as a diaphragmatic node just here, but the spleen's okay, the bone marrow's okay, so this would be stage 3 disease.
Yeah, okay, thank you. So I guess, Stephen, you're sort of going down the, ABVD versus escalated BCOP-DAC discussion. IPS, oh, sorry, I'm not looking at the wrong thing. Is the IPS relatively low?
It will be, yeah, it will only be 1.
Yeah.
I mean, I think so. Our local report was reported as diagnostic, basically. But, so,
yeah.
And she's desperate to start treatment, which is a bit tricky. But in terms of the decision about the chemo, she quite strongly favoured the idea of BCOP-DAC. She has been to Oxford to talk to the fertility people, but it would cost £7,000, and with the delay that would bring in, she wasn't keen to do that. And I think I'm reasonably comfortable with that.
The alternative, Stephen, is to do the sort of AHL 2011 approach, so give 2 escalated BCOP-DACs and then de-escalate to AVD, and they've got quite good fertility data from that, showing, actually very well preserved fertility and very good outcomes.
Was the PFS about 88, 89% or something like that, wasn't it? So,
yeah, I mean, I think most people, me included, would think it's the same as the HD18 because they compared it with 6 escalated BCOPs and it was a bit lower in both, and it may well be a way the PETs were reported actually. So I would actually treat that as equivalent to an HD18 approach.
Yeah. Okay. But I mean, the main thing is about whether we're.
Yeah, I mean, funny enough, we had this with a case of ours, and I mean, the way we're sort of getting around it, and Dan, if you're still on the line, again, what's the quality of the core, can I ask?
It was a reasonable core, but very sclerotic.
Yeah, okay. Because the way we're doing it in Oxford is we're just going to get some wider bore cores on the patient, but it was a slightly dodgy core biopsy. So if you've got a good core biopsy, ideally we would get it taken out. I appreciate that's difficult though when it adds delay in. I do get that. I mean, you could discuss with the patient. I mean, I'd probably be saying, we're 90% sure, we need to be 100% sure, but it would introduce a little delay. Yeah.
I mean, the ENT guys are generally very generally help.
I think we'd have to formally recommend excision though.
No, I think we have to.
Yeah. Okay. Thank you.
If we're happy we get a diagnostic report, are you happy I don't need to come back here?
Yeah. Totally happy. Yeah. We know the stage, don't we? So yeah.
And review after 2 cycles.
Yeah. Thank you. And then if we just zip down to the last patient, I think that's the last one Dan feels he is needed for, and that is Alan England.
I think we've already reviewed the histology, but Alan is a 51-year-old patient who presented with enlarged neck nodes. He has no clear B symptoms, no significant comorbidities. So to review the biopsy, PET and discuss management, his ESR is elevated at 65. He's got no other symptoms otherwise.
Okay. Dan?
Yes, Alan England, we have a core biopsy from a left cervical lymph node, and this one is diagnostic for nodular sclerosis classical Hodgkin lymphoma.
Great. Great. Thanks, Dan. We can let you go now, I think.
Thank you very much. Cheers. Bye.
Cheers. Bye. Okay, should we look at the imaging?
Yeah, so this was the PET scan from Friday, and essentially they've got FDG out of the nodes along the left cervical chain between level 2 to 5, sorry. The most avid being a left level 2 node with an SUV max of 12.7. There's the occasional nodes on the right side, and possible involvement also of the left tonsil. There's nothing below the diaphragm, and spleen and bone marrow look okay, so this would be stage 2 disease.
Yeah. Do you think that right node is significant? It's always difficult, isn't it, when they're so small? But
yeah, these ones.
it's reasonably bright, isn't it?
And they're conspicuous on the myth as well. So there's
Yeah. Okay. So sort of stage 2 with 2. I mean, I guess it's 2 sites because I think the tonsil would, unless David disagrees, he's better than I am at these things. But tonsil probably all counts as left neck.
Are we calling that right neck though? Because the right neck would make it stage 2, wouldn't it? It makes quite a big difference.
Yeah. But it's whether it's too favourable is what I'm sort of thinking. Although he is 51, German Hodgkin's. Oh, how high is the ESR? Sorry.
65.
Okay, sorry, you did say that. Okay, that makes it a bit easier actually. Okay, so it is an unfavourable. So I guess we would normally sort of be suggesting. Well, we would normally be suggesting 6 cycles of chemo as sort of 2 ABVD, 4 AVD, but you could, it is actually quite localised though, isn't it? In which case we could go for a 4 and 30 approach if the radiotherapists think that's a good idea. I mean, it would limit his anthracycline exposure. What do you think, Joss and David? Yeah.
But you'd be irradiating both sides of his neck.
You would, yeah.
Quite a short length on the other side, but he would get a sore throat temporarily.
And his salivary glands. And I'd take the anthracycline. Yeah. I mean, he's 50. He's going to be fine with anthracycline. Anthracycline to breast patients.
I wanted to add on a point, Grant, which I should have mentioned. He's got quite a significant history of smoking. Yes, he's only 51. He smoked from 15 years of age.
Yeah.
Which was completely normal.
Yeah. No, thank you. I mean, it'd be fine from the anthracycline in the short term. I don't disagree, but just thinking longer term effects, it's late effects of chemo, etc. I'm always amazed how many people we see occasionally re-referred sort of 10 years after whatever, R-CHOP or whatever, and a lot of them have cardiac issues which haven't always been ascribed to the anthracycline. Anyway, yeah, so I mean, I think you could do either. I think it sounds like, I mean, I would probably be going for 6 cycles of chemo, to be honest, because but I would discuss it with the patient. I would imagine you'd probably get a slightly higher rate of cure with the radiotherapy approach, but with unfavourable disease, it's less marked than with early favourable. So I think there's not much in it, to be honest.
Is that about 3 to 5% increase with the additional radiotherapy?
I think that's fair. Yeah.
Okay. Sure. Thank you.
Okay, thank you. So sorry to jump around. Let's go back to, I think we're on Stephen Kelly now.
Yeah, I think so. His biopsy must not be ready then because it was referred to there on Monday.
Okay, sorry. Yeah, I can't ask now because
His PET is not ready, but quickly, if we can discuss, he's 51, he has long-standing hypertension and has an ejection fraction in 2020 of 45 to 50%, and the recent one, 2022 is 50 to 55%, and with an LV concentric hypertrophy and significant lymphadenopathy of his left axilla and left neck, about 6 by 6 centimeter, with a slight LDH of 237. Local report is CD10 positive, like a germinal center diffuse large B-cell lymphoma. That is happening tomorrow. His BMI is 42, weight is 135 kilograms. So I think we need an echo, a more recent echo to start, and I'll probably see him to say that, because if I request an echo, they will start saying this is for chemotherapy. So it's better I tell him that his biopsy has come back as lymphoma, and then wait for the rest of the results. But with that kind of ejection fraction, will you be giving him everything like normal, like Archer?
yeah, I think so. I mean, if you have a friendly cardiologist, it might be worth just asking them, because hypertensive changes in a heart, they are a risk for anthracycline cardiotoxicity, not necessarily heart failure, but an anthracycline is the best drug to have with high-grade lymphoma. That's always the issue. So I would be planning to go down that route. Anything over 50%, generally speaking, I'm comfortable with. But as I say, with the other changes on the echo, it might just be worth asking a cardiologist. They might suggest putting him on an ACE inhibitor if he's not always already on it, that sort of thing. But yes, I would be.
Okay, thank you.
Okay.
Yes, please, yeah.
Yeah, so we'll defer, shall we, that one? Yeah. Elizabeth Kington? Or have we Oh, that's the Hodgkin. Sorry, we've just done her. Beg your pardon. Rona Noble, I think we're on.
Rona Noble's known CLL from a couple of years ago, atypical CLL, 14 negative. Original MDT was just watch and wait. She didn't have significant disease, but now she's got markedly increasing lymphadenopathy in 3 sites: axilla, neck, and groins, and spleen. And I think she's very keen to have some treatment now. So this is to review her CT treatment plan. We've got her GBH status, I think.
It's
mutated. All right, sorry, I haven't got the result.
Mutated, you say?
Yeah, mutate.
Okay. Let's look at the imaging, shall we?
Yeah, so her previous imaging is on the right from 2022 and her current is on the left from the 13th of April, and she's got obvious, as you say, disease progression, particularly cervical. There are sort of numerous lymph nodes rather than one bulky lymph node with increased soft tissue around Walde's ring. And as you say, bilateral axillary lymphadenopathy, which have increased in size and number. The largest measures about 3 centimetres in maximal dimension. No significant, really, mediastinal hilar lymph nodes. New splenomegaly, spleen measures up to about 15 centimetres. Relatively small volume retroperitoneal lymphadenopathy, which has progressed, but more significant pelvic sidewall lymphadenopathy. So disease progression above and below the diaphragm.
Okay. And patient otherwise needs treatment, it sounds like, from what you're saying. So I like to have a go at these, but Toby, obviously do chip in. I mean, my understanding is that with mutated in a patient over 70, the results of Veno are extremely good, and it's fixed duration. I don't know if there's a trial, Toby, or if you'd have any other comments. But
I mean, I wouldn't look any further than Veno, to be honest. I think that you may cure her with like 1 line of therapy, and it'd be fixed duration. So she'll spend most of the rest of her life off treatment, and it's the only opportunity to do that. So in the low genetic risk patients, Veno is, to my mind, the standard of care. I+V, I would reserve for younger patients with higher risk disease as fixed duration, although the mutated patients do very well because they do very well with everything. But Veno is a good balance of fixed duration and relatively low toxicity. So if you think she's good for it, I would do that. So I agree, Greg.
So glad you agreed with Toby. That sound okay?
Yeah, that's fine.
Really high risk of TLS though. Yeah.
Well, what's her biggest node?
3 centimeters, and that's at a push. It's,
Yeah. And what's her white count? So she's going to be intermediate at worst, and her white. Sorry.
White cell is 200.
200.
Yeah, it is quite high.
But by the time you start the venetoclax,
Yeah.
it will almost certainly be near normal, if not normal, and her nodal disease won't be highly likely to be any worse, right? So she'll probably, if her white count's normal by the time you start Ven-O, she'll probably actually be low risk. You can be conservative and manage her as intermediate risk, but either way, you can dose escalate her as an outpatient.
Thank you.
All right.
Thank you.
Okay. Next patient is Nicholas Saltz.
Pets tomorrow.
Oh, yes, sorry. Defer, because we don't have a pet.
So we'll defer. Yeah.
Yeah, please, by 1 week.
Okay. And then I think we've done the last patient. So I think we're done.
Patients are on lists. I'm not sure if you got them.
Okay, I think the problem is we've not had an MDT coordinator, our usual MDT coordinator this week. We have had some problems, so we don't have any more pro formas our end. If there's anything urgent, we can discuss, but
there is an urgent.
Yeah, but that's a patient referred from last week, but she's actually now gone to hospice. This is the patient from dermatology who had extensive cutaneous nodules and not responding to phototherapy, but she has now new cardiac failure and raised AFP, and she is not quite. We talked about biopsy last week, which was not ready, but I think it's not needed to be discussed. We can wait for this. She has gone to hospice.
fine. Thank you. Yeah, I heard about that case. Rebecca saw her, didn't she? Here, but yeah.
He's 89.
There is a patient I want to discuss, if that's okay. His name is Mr. John Delara. We've got a PET scan to review, but basically he's a 57-year-old gentleman with a neck and abdominal mass diffuse large B back in I think November last year. Had 6 cycles of polar arching and really did very well clinically and generally speaking. We finished 6 cycles, I just want to say 29th of February, just to be exact, and got a PET scan to review, because we, in the last couple of MADs, we said we might need to consider radiotherapy or others. The other thing, unfortunately, I don't have the MIC, the fish MIC from the original biopsy on our system, and I was wondering if somebody can have a look, but that's for a different day, probably.
Okay. Yeah.
So, can you see the images?
Yep. Yeah.
So this is the MIP on the right-hand side from baseline. You've got the one in the middle from December and the current on the left-hand side. So it starts off with a conglomerate mass here with just a small residual focus above liver here and just an equivocal focus in the right side of the neck. Now, all the baseline sites of disease are looking good below liver, apart from a tiny focus within that retroperitoneal mass, which has actually got more intense compared to December, and is more than 3 times that of liver as well. So this is just a representative fused axial image here on the right. The overall mass now measures 36 by 20 millimeters and was 47 by 54 millimeters on the interval scan.
Sorry, can you repeat those again? So has it got smaller or bigger since the interval?
Yeah, it's got smaller in size, but there's a that's more intense. There's no new sites of activity elsewhere. Just other things, just as an aside, there's just a tiny focus in the liver, which I think is probably just misregistered from gallbladder, but worthwhile just following up. And the other thing just to highlight is that there's some fairly intense uptake just around the anal margin and also in the rectum, which seems to be a bit new from before, so just worth assessing directly.
Okay, we'll leave the PR up to you guys, but so that the AVID area, is that biopsyable?
Tricky. It's between the duodenum and the IBC, so potentially endoscopically, potentially, yeah.
It's that thing there.
Yeah.
It's tricky, isn't it? I mean, it's not huge, but it worries me that the SUV has gone up. So do you mind telling me what the SUVs were?
Yeah, so the SUV max at the moment is 13.7. At baseline it was 23.6. I think on the interval it was around 6, I think. Let me confirm.
Okay. And is he, can I ask Joss, is he teed up for radiotherapy?
I don't think yet. I think
No, he hasn't been referred.
No, okay. You're waiting for the PET, maybe.
But that's where we bring it. We go for radiotherapy. I mean, it was very bulky in the beginning. I've also had the neck side was very bulky as well.
Yeah.
I'm really sorry, but even I can't remember the fish. We don't have the fish.
Oh yeah, no, don't worry. I mean, it's not that crucial, the fish. Yeah, I mean, it's a concern, and I think, you know, by Lugano criteria, which I'm not a great fan of, but it is progressive disease, and, you know, we wouldn't normally say radiotherapy is curative there. It's not really necessarily a PMR based on the interim. So I think if we can biopsy, and it sounds like we might be able to, I think we probably should. We could, in the meantime, have a chat with him about possible CAR-T, but I wouldn't want to, you know, we definitely need to get the result of that biopsy. So how much would he be freaked out about coming to have a chat about CAR-T?
I mean, he's very fit. He's very fit, and actually just want to get out of the way. And he thinks, you know, he's much better, and he's feeling brighter, and it's all, you know, that will be the end of it. Maybe better radiotherapy. He knows that it might be more chemo or something else to get this under control. I didn't specifically say CAR-T or something else. I literally said I'm going to discuss in this meeting and get back to it. So very, very fit at the moment.
Yeah. I think we should, you know, I think we should get a biopsy, and I think we should see him in the meantime for potential CAR-T, so that if it is positive, which it may well be with that imaging, we can get on pretty quickly.
So I'll refer to yourself, and I'll try to get a biopsy locally. Did you say endoscopy biopsy? Sorry, I missed that.
Yeah,
endoscopic biopsy.
We're doing a few of those. I hope it's helpful. They're not the best biopsies for lymphoma, are they? But if it's, you know, all we need is something that's compatible with high-grade lymphoma, and then we're home in trial. So.
It'd be good to bridge with radiotherapy, perhaps, even if you didn't want to try and salvage with radiotherapy.
Very good point. Yeah, thanks, David. Yeah. Okay. Thanks very much. I think that's all the cases. Thanks, everyone.
Can I just let you know that a query earlier, Henry Curtis, about what the Dable score was? Just calculated it, it's literally just under 3 times. That'll make it a DR4.
Yeah, okay. So officially a 4. Yeah. Okay, thanks very much. All right, bye then.
We're going back
Excellent.
to